Committee will come to order, and good morning. I want to thank I want to say thank you to all of our witnesses for being here. And when when I got home from the Marine Corps, VA was a different place. It was a long time ago too, by the way. It was slow, it was frustrating, and less modern. Now we've made progress, a lot of it, because of the work this committee, not only in this session, but over the years has done to make sure that it is moving into the modern world. But I'm not interested at all in patting ourselves on the back. There's still too much work to do. Today's hearing will be about making sure veterans have access to the best healthcare technology available, no matter where they live, what they've been through, or when they served. We're here to ask a few basic questions. What innovations are working? What's holding them back? And how can we move faster? Government delays and red tape should never be the reason a veteran can't get life-saving care. I support efforts to cut waste, eliminate duplication, streamline the way VA buys new tools and services. And from my seat as chairman, I am focusing on pushing VA into a modern agency, and I know it can be done. Acquisition reform isn't flashy, but it matters. And when it comes to bringing new technology into VA, the stakes are too high to let process get in the way. VA has said they want to partner with industry and academic leaders, and that's good. But we need to know that what that really looks like, who's getting through the door, and how long it's taking. Let's get past buzzwords. Veterans don't need more talking points, they need results. That's what House Republicans and the Trump administration are focused on. Over 30 million American lives over 30 million Americans live with diabetes. The VA, 1 out of every 4 patients have it. Heart disease is the #1 cause of hospitalization at the VA, and it kills 2/3 of our veterans who have diabetes. PTSD makes those things worse. It increases the risk of heart disease, it causes sleep issues, and veterans with chronic pain suffer more and longer than the average American. These are real challenges, but there are real solutions out there. Many of them are sitting in this room today. Still, innovation takes too long. A recent study showed that hospitals struggle to bring new products and tools. Budgets are tight, training takes time. But I want the VA to be the exception. Veterans can't afford to wait. That's especially true for rural veterans. Too many live hours away from care. They deserve access to the same devices and services as someone in the big city. That's what this hearing's all about. The people here today aren't just developing impressive technology, they're building tools that have veterans and give veterans more options, more access, more chances to live healthier lives. Our job is to make sure the system helps, not hinders that work. We owe that to today's veterans and to the veterans of tomorrow. One day, I suspect more of my grandchildren will be veterans, and I want them to walk into a VA that's not just functional, but forward-thinking, fast, innovative, at the front edge of modern medicine. So let's keep moving towards that goal. And with that, I want to welcome our witnesses and look forward to your testimony. And I now recognize Ranking Member Takano for his opening comment.
Thank you, Chairman Bost. I want to be very clear. Veterans deserve to receive gold standard health care. Veterans deserve access to the most cutting-edge medical innovations. And veterans deserve a VA that is fully staffed to deliver the world-class care and benefits they have earned. These are core beliefs that I hold. Achieving these goals depends on Congress meeting the true funding needs of VA, But under Trump and Secretary Collins, VA leaders are being forced to make impossible choices. Cut after cut after cut. To personnel, contracts, and veterans care, all in the name of so-called efficiency. These cuts are not making VA more efficient. They are forcing VA to decide between keeping staff on the floor and investing in expensive equipment that may sit idle without enough personnel to operate it. Let me say it again. The gentleman that before us today to talk about the innovations and the medical equipment that they want to sell VA, that there may not be the personnel that's trained and ready to operate that equipment. If the draconian cuts at VA were improving care, VA would be here telling us about it. But what we are actually hearing are reports of the exact opposite. So on poster number 1, this is a prosthetics customer service center shut, but has its doors shut in Grenville, North Carolina, the VA clinic. Prosthetics are, you know, the artificial limbs that veterans need. That is a VA facility that's been closed in a member's district who sits on this committee. Poster number 2, DOGE has canceled a contract for a mobile MRI unit at the Danville VA Medical Center. And then finally, here's a contract for supply chain management support, canceled by DOGE. As we sit here today, instead of sending officials to testify before us, VA leaders 2 miles away at central office are planning how they're going to fire over 80,000 additional employees. Unfortunately, due to the financial reality VA currently faces and the uncertainty about the future of VA's workforce, medical center and VISN directors have to make either or decisions routinely. Either or. New cutting technologies or fully staffing VA. In many cases, staffing VA and able to facilitate the operation of these new innovations. Just a few months ago, we heard from a VA medical center director who told us that he had to put off purchasing a new telemetry unit and hiring additional staff to operate it because his budget had been eaten away by skyrocketing community care costs. We know for a fact that there is expensive medical equipment sitting idle in VA facilities across the country because it does not have the staff to operate or maintain it. We're talking about medical equipment that already exists at VA. We're missing a whole side of this conversation today, and that's no accident. The majority deliberately chose not to invite VA to testify, shielding the department from the responsibility and real oversight this committee is supposed to provide. When the minority invited VA to send witnesses, VA declined. I'll say that again. VA declined the minority's invitation to be here today. The majority decided that we don't need to hear about VA's actual need for these devices, that we don't need to hear how VA will pay for these investments, and they did not care if we heard whether VA has sufficient workforce to provide the manpower and follow-up maintenance that is necessary with machines and devices like the ones our witnesses sell. Without VA here to provide, without VA here to provide the other side of the story about the on-the-ground reality of veterans' needs, all you're going to hear today is a sales pitch, and indeed an expensive one at that. VA leaders also deserve to speak about the department's proud history of research and innovation. VA has long been at the forefront of biomedical breakthroughs that have saved millions of lives, breakthroughs that corporations like Philips and Boston Scientific have profited from. For instance, Dr. William Oldendorf, a VA neurologist at the West LA VA Medical Center, developed the first prototype and held the first patent for a CT scanner in 1963. Philips now sells CT scanners to VA. Likewise, Boston Scientific would not have been able to develop and sell its pacemakers had it not been for the groundbreaking research of Dr. William Chardick and Mr. Wilson Greatbatch of the Buffalo VA Medical Center in 1960. But if VA is to remain a leader in medical renovation, we need to invest in its research infrastructure, not outsource that expertise to private companies whose bottom line takes priority. Now, VA should be here. That's exactly why I find the timing and participants of this hearing so strange. At a time when Secretary Collins is cutting research, slashing staff, eliminating worker protections, and canceling critical contracts, my colleagues across the aisle are suddenly eager to talk about innovation and the brand new equipment VA needs to buy? How tone deaf is that? I don't believe the Trump administration is setting VA up for success in providing basic care for our veterans right now, let alone creating an environment that will lead to groundbreaking innovations. I have to say, if things continue at this rate, the time of VA as an innovative force will be behind us. I'm not willing to see that outcome come to pass. My colleagues across the aisle talk a lot about making hard choices to get our country's finances back in line, but let's be clear. Those hard choices should not mean choosing between veterans' care and corporate profits. And right now, VA facilities are being forced to decide whether to keep the staff they need to provide veterans quality care or spend billions on expensive high-tech equipment sold by for-profit companies whose promises are not to our veterans but to their shareholders' bottom lines. I'm worried that we're not even getting to be able to fulfill the fundamentals of care and benefits for veterans if Trump and Collins keep arbitrarily cutting staff and resources. I want the veterans VA serves to have it all: world-class care, cutting-edge innovations, and a fully staffed VA that is prepared to meet their needs today and in the future. But that future is at risk if we continue down this path of arbitrary cuts and misplaced priorities. We cannot allow VA's mission to be undermined by short-term cost-cutting or long-term privatization. And with that, Mr. Chairman, I yield back.
Thank you, Ranking Member Takano. And it's great to see that jet lag has not affected your ability to deliver messages.
Oh, thank you. Glad to see you here this morning, too.
We both got in from Japan yesterday. It's wonderful with where we went and what we did. But we will now turn to the witnesses' testimony. Now, testifying before us today, we have Mr. Will Gray, Vice President for Marketing, Commercial Operations, and Government at Boston Scientific. Boston Scientific has made advances in the medical device field using stents, among other technologies. We also have Dr. John Bloom. He's the Chief Executive of Podimetrics, and Podimetrics has partnered with the VA on programs calling the Initiative to End Diabetic Limb Loss at VA. We also have Mr. Jeff DiLullo, Executive Vice President of the Chief Regional Leader of Philips North America. Philips North America offers a range of products that, among other functions, utilize imagining to create visual representations of the body's interior. And we also have Dr. Parthasarathy, Director of the Center for Sleep and Neuroscience Research at the University of Arizona Health Science. The university has invested in sleep apnea research, among other areas. Will each of the witnesses please stand and raise their right hand? Do you solemnly swear that the testimony you're about to provide is the truth, the whole truth, and nothing but the truth? Thank you. You may be seated. Let the record reflect that the witness all answered in the affirmative. Mr. Gray, you are now recognized to deliver your testimony for 5 minutes. And I will explain the light system here. Red or green, you're going. Yellow, it's coming to a close. And red, you better get her stopped. And I don't want to play rodeo and throw you out in 8 seconds. So there we go.
Great. Thank you. Chairman Bost, Ranking Member Takano, and distinguished members of the committee, thank you for the opportunity to testify today. My name is Will Gray. I'm a proud Marine and have spent the past 25 years at Boston Scientific. For the past 13 of those years, I've focused on the commercial strategy in the VA and the Department of Defense, ensuring that veterans and military personnel have access to life-saving medical technologies. I also lead our marketing and commercial operations strategy for Boston Scientific for our largest civilian healthcare systems. This role gives me a unique perspective on how advanced civilian hospitals provide care in the quadruple aim, and that's efficiency, quality, cost, and patient satisfaction. At the same time, I remain personally dedicated to the veteran community, mentoring and advocating for those that have selflessly served our country. Boston Scientific is a leading U.S. global medical technology company headquartered in the Boston area. We have a strong U.S. presence in manufacturing and research with thousands of employees in states like Massachusetts, Minnesota, Indiana, Texas, and Georgia. We focus on technologies that address major health needs in the veteran population: pain, heart disease, stroke risk, and neurologic and gastrointestinal disorders. Over 65% of veterans suffer with pain. To help reduce opioid use and improve quality of life, we offer non-opioid solutions like spinal cord stimulators, which deliver personalized pain relief. For veterans with atrial fibrillation, our Watchman device offers a safe alternative to blood thinners, reducing stroke risk through a minimally invasive procedure, and those patients are 5 times more at risk than those without atrial fibrillation. We've also developed FARAPulse, a pulsed field ablation technology that's truly transforming how atrial fibrillation is treated. In less than a year, that therapy has become the dominant type of treatment for AFib, for EP ablation, taking over for RF and cryoablation. For those patients and veterans with peripheral artery disease, our technologies help keep arteries open and prevent repeat procedures and potential limb loss. For the heart, we have an agent drug-coated balloon, which was just FDA approved, that delivers medication directly to the artery, reducing the chance of blockage for stents. These innovations have already improved care in civilian hospitals, and all veterans deserve the same access. The VA has made meaningful progress in integrating clinician voices into its procurement system. In 2017, we worked with other companies in this committee, alongside Representatives Scott Peters and General Jack Bergman, to help improve the MedSurg Prime Vendor Program. This effort brought clinical expertise into purchasing decisions and created a rolling process for adding new products. I would say the MSPV today is a model for how clinician-led sourcing can work. And today, we're working with this committee to apply those same principles on the Prosthetics and Sensory Aid Services, or PSAS program. Again, ensuring that clinicians are part of the procurement process helps ensure product decisions reflect the needs of veterans. And this is what we do on the civilian side as well. Having physicians and clinicians involved in that process is critical. Despite these successes, challenges remain. Technology adoption is often delayed due to staffing shortages, budget unpredictability, and inefficient procurement workflows. One example is that pulse field ablation technology I talked about that has become the dominant therapy for EP ablation. In the US, we project 61% of EP ablations will occur with pulse field ablation this year, right? 61%. But less than 10% of VA hospitals have access to that therapy, less than 10%. To address this, we recommend the following: a transparent, predictable budget process at the hospital level. That's number one. Number two, hiring and training more procurement staff. Number three, adding 2 product cycles when you can add products on all national contracts. You have it on the MSPV. We recommend you put it on the PSAS as well. And then consider an innovation fast track for high-impact technologies. Again, the VA has made commendable progress in modernizing procurement, especially through clinician engagement. But more must be done to ensure veterans receive timely access to the technologies available in commercial hospitals. Boston Scientific is proud to support the VA, this committee, and all those working to improve care for those who served. To this committee, I thank you for your service to our veterans, and I thank you for your time.
Thank you, Mr. Gray. Dr. Bloom, you are recognized for 5 minutes for your opening statement.
Chairman Bost, Ranking Member Takano, and distinguished members of the committee, thank you for the opportunity to testify today. I'm Dr. Jonathan Bloom, a physician and the proud son of a decorated Vietnam veteran who is sitting behind me today. I co-founded Podimetrics over 13 years ago after spending way too many whole days in the operating room doing nothing but amputations for diabetes. Essentially Civil War medicine, limbs we could have saved with early intervention. A staggering 1 in 4 veterans have diabetes, double the rate of non-veterans in our nation. Compromised blood flow into the limb and diminished sensation in the feet, both the result of unchecked diabetes, can result in a diabetic foot ulcer, a typically silent wound to the bottom of the foot. Veterans and caregivers are often unaware until the wound is open, infected, life-threatening, and requires emergent intervention, a life-altering amputation. In fact, 85% of lower limb amputations are a result of a diabetic foot ulcer. And most crazy enough, the 5-year mortality after a foot ulcer is 70%, which makes it worse than almost all cancers that we have. And then, of course, each year, the VA estimates that they spend approximately $3.2 billion in direct expenditures just caring for diabetic foot ulcers, and more recently, $3.5 billion. I've been working with the VA for over a decade to develop a solution to prevent diabetic foot ulcers, starting with our very first clinical trial in the VA in 2013. 7 years later, in 2020, after years of research and study, we formalized our partnership to develop and deploy a remote temperature monitoring program with the Podimetrics SmartMat called the VA's Initiative to End Diabetic Limb Loss, supported in part later on, thanks to all of you, through the 2020 CARES Act. And here it is real quick here. Basically, from the comfort of a veteran's home, a veteran stands on the SmartMat for just 20 seconds a day while they're brushing their teeth or combing their hair. The mat then scans for temperature changes in the feet, which may indicate a developing foot ulcer. The data is then securely transmitted for analysis without the need of Wi-Fi or mobile device, allowing a clinician to intervene hopefully in time to prevent the complication before it occurs. The impact of this collaboration has been remarkable. VA-led research suggested that clinicians could detect 97% of diabetic foot ulcers on the bottom of the foot over 5 weeks before they would have otherwise recognized them. VA research presented last year suggested participation in the program resulted in a 37% reduction in 1-year mortality. That equates to 1 veteran life saved for every 23 veteran participants who came into the program in just the first year alone. In March of last year, fewer than 6% of eligible veterans enrolled for 12 months. With that population, the VA reported that it had saved an estimated $100 million over that period, almost $16,000 per veteran participant per year. If scaled to all 110,000 veterans at the highest risk of a new diabetic foot ulcer, this program could save approximately $1.8 billion annually to the VA, to U.S. taxpayers, and save approximately 5,000 veteran lives in just that first year. Partnering with the VA, we have proven remote temperature monitoring that the program works, but scaling this technology to every eligible veteran remains a challenge. I want to share 4 observations that I've seen over my 10+ years working with the VA on foot ulcer prevention. One is that rural and low-income veterans still struggle to gain access to the system relative to their counterparts. It's still a challenge. 2, almost all enrollments come from VHA podiatry, yet only half of at-risk veterans get their podiatric care at the VA. We must ensure equal access regardless of their geography or circumstance. No veteran should be left behind. Number 3, budgeting silos do affect veteran care. The prosthetics budget pays for the system, but most of the savings goes to medical care. Budget must be protected to ensure that we don't save a little spend in one silo at the expense of dramatic savings in another. These budgets do not coordinate as they work together. And then lastly, the workload credit to do an amputation is dramatically higher than the workload credit to prevent one. Until incentives are fixed for this complication, the VA will struggle to deliver preventive care. And stated hyperbolically, we have all the people we actually need, they're just too busy treating preventable complications. To close, in most of your districts, right now, Podimetrics and the VA Remote Temperature Monitoring Program are improving our veterans' health care, but almost 100,000 veterans still need access, over $1.5 billion in lost savings each year. No veteran should walk into a hospital one day and then leave in a wheelchair or worse, not at all, especially when we have the technology to prevent it. Thank you, and I look forward to your questions.
Thank you, Mr. Bloom. Mr. DiLullo, you're recognized for 5 minutes.
Chairman Bost, Ranking Member Takano, and distinguished members of the committee, it's an honor to be before you today. My name is Jeff DiLullo. I have the privilege of serving as the CEO of Philips North America, leading a dedicated team of 17,000 professionals, many of whom are veterans themselves. Philips is a global health technology leader, delivering AI-enabled solutions in diagnostic imaging, such as MRIs or CT scans, non-invasive cardiac procedures, and patient monitoring solutions spanning from hospital to home. Our mission is to improve the lives of 2.5 billion people per year through meaningful innovation. And nowhere else are we more focused on this mission than in serving America's warriors. At Philips, we get to serve heroes, and we know that. And we do this by putting our innovation to work specifically for the VA. Some examples: a critically needed MRI in the aftermath of a battlefield trauma, helping clinicians to monitor veterans remotely because we know veterans recover better at home, accelerating precision detection and treatment of cancers, and bringing the highest quality cardiac care to our veterans. Our mission is clear: to support the best possible care for those who have defended our freedom. And for me, the mission is also a personal one. I'm a graduate of the United States Military Academy. I served as an infantry officer and an Army Ranger. More importantly, I'm a proud father of a soldier. Every morning, my daughter, Emma, dons the uniform of a U.S. Army officer, having answered that same call to serve. At some point, she will rely on the VA for her health care. That's why my work is not work, it's personal. Philips has been a proud innovator with the VA and a partner for more than 50 years, helping design and deliver innovative solutions to improve care for millions of veterans during that time. In fact, when a veteran walks into a VA medical center today, there's a better than 50% chance they will interact with a Philips piece of equipment. Innovation exists today, commercially, that will improve veteran patient experience, relieve workload on we know stressed VA staff, and reduce the overall cost of delivering that care. And in several areas of innovation, we are proud to say the VA has already demonstrated a clear leadership. For example, in 2020, the VA implemented, with Philips' help, Telecritical Care Program, or TCC, which utilizes a secure digital infrastructure and network to connect all VA intensive care units. TCC digitally leverages critical care nurses and specialists from other VA locations across the network for real-time support and better monitoring in high acuity settings. The VA has done an incredible job with the TCC program. It's a banner example to any health system, and I talk to every health system in the nation. Better patient care, better staff utilization, it just works. We believe also the VA should expand virtual nursing support by using existing technologies to develop more comprehensive virtual nursing programs for lower acuity settings, which is the vast majority of care, like medical surgery units, stroke units, and emergency departments, where timely interventions are critical and where staffing continues to be a challenge. The opportunities for virtual care go far beyond nursing, however. The VA handles more than 25 million diagnostic imaging scans annually. That is a staggering number of scans. Today, the VA radiology departments often operate largely independently, relying on their own resources, their own capacity, and their own expertise. Radiology is a complex discipline. Creating a network that connects all VA radiology departments, distributing the remarkable expertise of VA radiologists would allow facilities to share expertise, improve utilization of those radiology teams in the same way it currently does with TCC. The Philips Radiology Operations Command Center, we call it ROC, not to be too cute as an infantryman, we call it ROC, an innovative solution that allows technicians in a central command center format to connect with technologies operating imaging machines in real time across many locations in the network, not just Philips locations, any location, any original manufacturer piece of equipment, we can do it across any. These technicians can remotely deploy protocols, conduct, view, and fine-tune imaging exams. The approach standardizes image acquisition, quality, and reducing rescan rates, or think of that as veterans revisiting for a scan, and ensures more accurate diagnosis with smoother workflow for clinicians, saving time across millions of scans a year. We also have AI-enabled solutions in the scanning process that itself can dramatically reduce scan times for veterans, enabling the same staff to schedule more veterans per day with significantly lower sedation rates. These are just a few of the examples of the opportunities available today, commercial technology today, when they're more needed than ever. Better care for veterans, better experience for VA clinicians, lower cost for taxpayers. Chairman Bost, Ranking Member Takano, thank you very much for holding this hearing today. Thank you for your unwavering dedication to those who have served our nation and those that defend our freedom and their families. And thank you for asking us to show how we can deliver smarter technology to serve those who protect America. I look forward to answering your questions. Thank you.
Thank you. Dr. Parthasarathy, you are recognized for 5 minutes.
Thank you, Chairman Bost, Ranking Member Mr. Takano, and distinguished members of the committee. It's an honor and privilege to give my testimony in front of you today. My name is Sairam Parthasarathy. I'm a professor of medicine and chief of pulmonary, allergy, critical care, and sleep medicine at the University of Arizona and in Tucson, Arizona. I've previously served in 2 Veterans Affairs hospitals, both at the Edward Hines Jr. VA Hospital in Hines, Illinois, as well as at the Southern Arizona VA Healthcare System in Tucson for a total of 11 years, where I served as section chief for pulmonary, critical care, and sleep medicine, and also subsequently as chief of research at the Southern Arizona VA Healthcare System. I speak to you today as a member or board of director for the VA nonprofit affiliate at the, also known as the Southern Arizona VA Healthcare System Biomedical Research Education and Foundation of Southern Arizona. I'm board certified in pulmonary, critical care, and sleep medicine. I'm here to talk about the area of my research expertise, which is, has a special focus on implementation science in the area of sleep medicine. The approach of implementation science entails harnessing new biomedical innovations and bringing it to the bedside and clinics to benefit patients and veterans everywhere. Hence, I believe that I can speak to the topic at hand, which is regarding harnessing biomedical innovations, modernizing VA healthcare system for the future. Essentially, a wealth of scientific knowledge is being generated by biomedical research, especially in the area of sleep and circadian science, which has cross-cutting benefits to veterans' health in every organ system. In order for us to realize the full return on investment to such scientific knowledge and to improve the health of veterans and the nation, especially with the extent to which chronic disease afflicts our people, there's a dire need to disseminate and implement, or simply put, harness these research findings into day-to-day clinical practice. It is frequently reported that there's a time lag of 17 years before 15% of research innovation that is developed by research and science that's being brought to day-to-day clinical practice in order to benefit both veterans and civilians. Such harnessing, if you want to call that, has evolved into the science of implementations, and the Veterans Healthcare System and affiliated university partnerships are uniquely and well poised to thoughtfully harness and implement these wonderful innovations into the real world and benefit veterans everywhere. Implementation science takes into account the healthcare provider's work-related burden in a busy clinic or hospital system, and the validity and applicability of the scientific findings to that context. The ability to get clinics to adopt these practices and maintain them over time is another crucial aspect that needs to be taken into thoughtful consideration. We need to carefully assess the metrics that will measure the process of implementation and return on investment for us to exercise proper financial stewardship. We need to identify barriers for implementing these medical innovations and identify facilitators to better assist with such implementation or harnessing efforts. So essentially, we need to perform a shifting of the task from the busy healthcare providers to machines that can work hand in hand with them. One such example is in the area of sleep apnea, which is an area of my expertise. And sleep apnea is very common in veterans and is characterized by repetitive obstructions of the upper airway throat and cessations of breathing and low oxygen count. Both sleep apnea and insomnia have been associated with heart attacks, strokes, high blood pressure, road traffic accidents, poor outcomes in individuals with traumatic brain injury, PTSD, depression, suicidality, and even death. However, 1 in 4 individuals remain undiagnosed with sleep apnea, and many with insomnia, and the remaining individuals are left undiagnosed. So we and others have refined machine-based algorithms that are developed by various researchers, including at MIT, that embed into electronic medical records within the system of the University of Arizona healthcare system, which can identify individuals with high likelihood of sleep apnea and alert healthcare providers to the fact that they have it and enable them in a facile manner to play diagnostic tests and enable treatments to be brought to fore. Moreover, treatment of sleep apnea with CPAP machines and other treatment devices that can help keep the throat open can reduce motor vehicle accidents, reduce blood pressure, reduce cardiac deaths, and in about, unfortunately, only 2/3 of people with sleep apnea adherent to such treatments. And there are not enough providers and caregivers to support this. So we need AI/ML-based algorithms that need to be developed, which we have developed with funding from the Veterans Affairs Health Services Research and Development, as well as from PCORI, to help veterans and civilians to be adherent to treatment and to derive the full benefits from such treatment. And so there are similar machine-based approaches for behavioral therapies as well. So in summary, there are numerous approaches to successfully identify and treat individuals with these medical conditions in the sleep space with AI/ML approaches. And there's now more than ever a need to harness these biomedical innovations to improve the health of veterans using such technology. Thank you.
Thank you all. Now time for questioning. I recognize myself for 5 minutes. Mr. DiLullo, could you tell us about your experience with the acquisition process at the national level and at the facility level as well?
Mr. Chairman, thank you for the question. I think our general experience is we have a limited number of national level acquisitions that we do. Typically, in the nature of the business that we're in, those budgets typically are held at the VISN or below level. So we typically compete for localized contracts or consolidations at the local level. We see a distinct difference in how we would deliver capabilities around software and more advanced AI capabilities that should be more at the enterprise level. And I think the budgeting of that would be an area we would want to express or explore with the VA in more detail to show the total economic value creation of those solutions.
All right, thank you. Dr. Gray, or Mr. Gray, Boston Scientific engages with VA through a number of different contracts. Is this variety of contracts appropriate, or should we process be streamlined?
Thank you, Chairman, for the question. I would say that our contract status at Boston Scientific is very good. We have almost all of our products throughout all divisions of Boston Scientific on a national contract. As I mentioned before, the MedSurg Prime vendor, I would say, is an excellent contract, one that allows clinician input. It also allows us to add products twice a year. It's pretty easy for us to get products on. The other one is the PSAS, the prosthetics contract I also mentioned. I would say that one is more challenging, and we're working with this committee on improving that so that, again, clinician voice, 2 different periods per year where we can add products. And that's one of the big challenges when we have an implant or a piece of capital. It's very difficult to get it on that contract in a timely manner, and that's why we're not able to get some of that technology quickly to the veterans where they deserve it.
Thank you. Dr. Bloom, 1 out of every 4 veterans suffer from diabetes. How is your company's work helping prevent long-term complications and reduce hospitalization among this population?
Well, certainly one of the most dreaded complications of diabetes we talked about, the diabetic foot ulcer. What isn't as well recognized is that when you have an open wound, you are twice as likely to be hospitalized for heart attack, stroke, CHF exacerbation, COPD exacerbation. It tips the bodies over to have a number of very costly complications. So if you're able to prevent that foot ulcer from recurring, you typically can prevent this cascade of bad outcomes and costs. So that's what we've been able to do in partnership with the VA, is to build a tech and a program around it to identify those veterans early, get them the care the moment we see an issue, and ultimately show the savings, which I believe the VA last estimated about $16,000 savings per patient per year by being in the program.
Dr. Parthasarathy, veterans with post-traumatic stress and chronic pain often face serious sleep disorders. How is your work helping veterans treat these issues?
Yeah, sleep apnea can actually make PTSD worse, and it can actually cause traumatic brain injury to not heal as quickly as possible. Some of the technologies with colleagues here at the University of Arizona and elsewhere are using artificial intelligence, deep learning, for developing virtual imagery-based diagnostic tests in order to be able to quickly, within 20 minutes, diagnose someone with PTSD and can even be used in the war theater, where 4 hours of a neuropsychologist actually doing a cognitive exam is going to be difficult. So some of these technologies are able to assist with diagnosing, but also with regards to therapies and desensitizing people with PTSD and help improve, not just with medications, but also by be able to deliver cognitive therapy using machine-based approaches.
Thank you. And I want to thank all the panelists because, that's what today's hearing is about, is the technology that we're moving forward with, each with unique situations where before we would only be able to start dealing with the problem when the problem, and don't do anything to prevent the problem. So much of this will save in the long run, not only for the veteran health care that we spend, but also for the veterans and the improvement of their lives. So with that, I'm going to yield my time back and recognize the ranking member, Mr. Tano.
Thank you, Mr. Chairman. Well, before we even consider investing in new expensive equipment, we need to ask, can VA afford to operate and maintain this technology without sacrificing essential staff and services? In light of this administration's ongoing efforts to slash VA's workforce, VA medical facility leaders are facing hard choices. Every dollar spent on these devices is a dollar that VA cannot spend on retaining nurses, doctors, and technicians who are essential to delivering care. I want to avoid a situation where President Trump and Secretary Collins are imposing on VA leaders the necessity of having to choose so that veterans do not lose out on either the innovation or the staffing side. But to do that, we need all the information so that we can make sure we can make the case for more funding at VA. Mr. DiLullo and Mr. Gray, last week my staff contacted your companies to request certain information about the products you sell to VA. Your companies both declined to provide this information, claiming it is proprietary. If these innovations are truly cost-effective, why won't your companies provide the committee with full pricing information? This committee needs to know more, not only about what resources Congress needs to make available to purchase those products, but about your company's respective fiduciary interests in doing business with VA. I'd like to also give you an opportunity to provide this information to the committee. Within the next week, I want to ask, will you provide A, a list of all the products you sell to VA, B, the unit price of each product, C, the overall quantity of each of these products you have sold to VA, and D, the overall number of VA facilities that have purchased your products. Mr. Gray and Mr. DiLullo, will you do that in the next week?
So I would answer your question, Ranking Member. First of all, thank you for the question, and thank you. I know that we've worked with you. I was in your office in the past year speaking to you
Mr. DiLullo, I don't have a lot of time. I just need to know whether you'll provide that information with us kindly.
What I will do is provide the information that we have and how it got onto your national contract. As I mentioned before, we have the vast majority of our products that went through the process of getting it on the contract. Which
very respectfully, Mr. Gray, can we just get an answer to whether A, B, C, D, you'll provide that information to us?
That's proprietary information, and I'll get with my team.
So it's proprietary information. Thank you. Mr. DiLullo.
Mr. Ranking Member, thank you. I would suggest that pricing is very dependent on specific contracts that we work across the VA, so we can provide all of the information in material that we have sold to the VA. Those are contracts that we have in place, and we would be happy to do that.
Thank you. Thank you. So, Mr. Gray, yours is a no. Yours is yes.
We can provide our contracts and our contract pricing, absolutely.
So I'm going to tell you, Congress and the American people are entitled to this information. These are contracts. DOJ is canceling contracts left and right without even looking into whether, I just showed you on the board. They canceled the contract for supply chain management support. If we're going to get a handle on how much things cost, we need to know, American people should have a right to know what they're buying. And so, thank you. VA wants the engine of biomedical innovation in this country. And I'm concerned that we are now outsourcing that role to for-profit companies whose primary goal is maximizing shareholder profits. If we are serious about modernizing VA healthcare, we should be investing in VA's own research and innovation capacity, not handing over billions to private corporations. But the new administration is slashing VA's research left and right. Already, VA has indiscriminately fired researchers whose term-limited appointments have expired. They have delayed or outright canceled important clinical trials that veterans are relying on as their best last chance for care. And they are driving away some of the country's best and brightest, many of whom would be thrilled to contribute to veteran research this simply not worth the long-term uncertainty. If this continues, I'm very concerned that this VA that laid the groundwork for pacemakers and CT scanners, which your companies are making money on, will be no more. As a nation, we can't afford to lose out on the advancements that VA research has a proven track record of providing. And I'm disappointed that VA is not here to answer the questions I have about VA's workforce. However, to make sure that Congress can fulfill its oversight obligations, my colleagues and I will be sending a letter to VA demanding answers to many of these questions later today, and I hope VA officials choose to answer this letter. Thank you, and I yield back.
Gentleman yields back. Dr. Murphy, you are recognized for 5 minutes.
Thank you, Mr. Chairman. One of the things that drives me absolutely insane is inaccuracies and untruths that are being spoken sometimes. I'm a surgeon, so I don't tolerate that crap very well. The last administration, secretary came in here and by his own admission stated that they had overhired during the VA and that they didn't quite know what to do about it. So I'm glad that we now have an administration that actually has accountability as their #1 goal. You guys couldn't run companies if you didn't have accountability. You can't do that. And there's no reason that the United States taxpayer should not demand the same thing from its government. You know, the VA in Greenville, which by happens be in my district, and I've actually been in that, a few years ago during the Arizona scandal where we didn't get patients seen, bought, I think, $80 to $100 million worth of equipment. You know what that equipment turned out to be? Coat hangers. Because guess what? The VA didn't have the anesthesia set up, or couldn't have the anesthesia set up to do. So just pouring money into problems, as you guys in any company would know, doesn't fix the problem. The other thing, I would like to, for the record, correct the ranking member's statement about my VA. The prosthetics department at the VA in Greenville remains open during normal business hours, Monday through Friday, 8 a.m. to 4:30 p.m. to support the needs of veterans in the entire VA, Durham VA healthcare catchment. Letter for the record.
Without objection.
Thank you all for coming. I use a lot of your products and continue to use them. I will say that I always had a penchant for Boston Scientific over Cook, but they're not here to defend themselves. It's a great thing. I'm going to ask some hard questions, though, because I think that is important. I look at all the great innovations that you've had, especially the left atrial appendage thing. I think that was absolutely brilliant, whoever did that thing to help with clotting disorders. But the real question comes down, and I believe this is a fair question because I served on our hospital's administration for 3 years, is cost containment. How do we do that? Because, guys, you know, we have seen little last 15 years an absolute explosion in the number of remedies, interventions that can be done now. Boy, it used to be cardiac surgery was always, when I was coming through, a heart wide open. Now there's so much that's being done innovative-wise to keep the patient out, send them out the next day. But I'd like to know what each of you are trying to do for cost containment. This is critical for our nation. It is wonderful to be able to develop these things, but how the hell do we pay for them? And throwing money at problems doesn't solve the problems. So, Mr. Gray, if you guys will give me a 15-second answer, that would be great.
Sir, we definitely focus on cost. I think the one thing that I have to give a lot of credit to the VA is, and the contracting establishment with the MedSurg Prime vendor and the PSAS, it's a very rigorous process. It's much more rigorous than civilian hospitals. So clinical data, comparison pricing, obviously features and benefits, that kind of stuff. Any other kind of Similar type of customer pricing, we have to provide that too. So from a cost perspective, the VA really
Great.
drives a
Dr.
tough
Bloom.
process.
Yeah, a few moments in prevention or having a patient walk less for 2 weeks has the potential to save an amputation, which can cost as much as $100,000. So I think it's critical. We would be happy to talk pricing. We're trying to give at least a 4x return on invested capital to the systems we do.
Mr. DiLullo.
Congressman, I'll go back to my Radiology Operations Command Center. We can deploy radiology exams into communities closer to where veterans live at a much lower cost than you would in a high-care acute cost center. That immediately takes cost out of the exam.
I think AI with what you're doing with your pathology stuff is going to be, it's groundbreaking because that's just pattern recognition, and that same thing a lot with radiology as move forward. Sleep apnea, how do you guys save money?
Just diagnosis and treatment of sleep apnea is one of the most cost-effective approaches to changing the paradigm of reducing heart disease and major cardiovascular events and hospitalizations and deaths.
And this actually, if people will understand this, when you save money and you deliver more efficient care, it is better for everybody. Throwing money at problems does not solve them. Being smart about them and efficient about them is how we solve problems. So look, I believe in competition, and it's good that Cook is around because you guys wouldn't be as good if you were, had they not been around. And so I think this is very critical, that I'm glad that accountability has now come to Washington, D.C. No one would run a business, as I said before, without it, and this is the way we need to run our government. So thank you all for coming. Mr. Chairman, I'll yield back.
Thank you. Representative Brownlee, 5 minutes.
Thank you, Mr. Chair, and thank you to the panel for being here today. While I appreciate all of your testimonies on how VA can and should be the world-class healthcare delivery system, and I appreciate all of your contributions to that end. But it is important that we point out the actions VA has been taking with the planned reduction in force of about 80,000 employees. That's a fact. The ongoing hiring freeze, that's a fact. And the haphazard contract cancellations, that too is a fact. And how the Trump administration is hurting VA's ability to fulfill its promise of delivering high-quality care to our nation's veterans. It is ironic that we are here today talking about biomedical technological advances when we are hearing of VA employees who are responsible for ensuring surgical suites, exam rooms, and inpatient rooms at VA medical centers are stocked with the basic medical supplies are being fired. We have already seen how getting rid of supply technicians and inventory management specialists has led VA clinics to delay or cancel procedures due to delays in getting critical supplies. We cannot let illogical policies of the Trump administration get in the way of VA delivering the care our veterans deserve. We must ensure VA has access to state-of-the-art equipment and medical supplies so that VA clinician teams can actually provide the care our veterans need. Mr. Gray, thank you for being here. I just wanted to mention that I have witnessed your spinal cord treatment for pain. Your Boston Scientific was in my district at one point, I think maybe 10 years ago or so, but I went there, visited with the team, and saw it, and saw what was going on, and it was really, the results are really extraordinary. And I also appreciate how your testimony acknowledges the challenges VA faces when it comes to procurement, and in which you provided recommendations for VA on creating an environment of stability and procurement through budget predictability, investing in procurement professionals to combat staff shortages, and modernization. So with the current slash and burn environment the Trump administration has created through this hiring freeze and a plan to cut 80,000 more VA employees, can you elaborate on how you see these executive actions impacting stability within the VA and its ability to continue working with companies like Boston Scientific?
Thank you, Congresswoman. I honestly can't answer that question because I don't know what positions are going to be eliminated. What I do know is exactly what you just said. You echoed my testimony, which is we have to have staff in there to order the product, to pay for the product. We have to have a process to be able to bring new products on. And we need physicians engaged in that process. That's really, really important. I've been thinking about an analogy. It's almost like every VA has an academic medical center affiliated with it, right? So a lot of times those physicians go between both. And if you have the great technology in the academic medical center and you don't in the VA, it's almost like if you have a snowstorm in two different houses, use a shovel in one and a snowblower in the other one. You still get the job done, but that clinician is going to want to go to the academic medical center where it's more efficient and fast. And so that's my concern.
Well, it sounds like you've had a good experience with the procurement process within the VA. Do you think it's a perfect one?
I've had a really good one with the MedSurg Prime vendor, and we've been challenged with the prosthetics one. So I will say the leadership in the VA has been wonderful to work with. In the last 5 years, there's been a real paradigm shift, in my opinion, in their willingness to reach out to suppliers like Boston Scientific and be partners and collaborate on solutions to bring products in. I've been really impressed with the leadership.
Thank you. For anybody on the panel, my next question is, as a business with VA contracts, with the knowledge that your contract could be cut at any moment, change how willing you are to continue to work with the VA? Any one of you can answer.
Congresswoman, I'll answer. It's a good question. We are here because we're devoted to veterans. And I think it's not a matter of whether we want to work with the VA or not, or whether it's a more profitable business for us to operate. We do this out of passion. We've been with the VA for 50 years, and we need to find creative ways. We are here to help work with you and the VA to find ways to creatively deliver these innovations to improve the productivity of the staff and drive better patient outcomes, better veteran outcomes into the communities where they live.
Great. My time is up. I yield back.
Thank you. Representative Barrett, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to the panelists. Appreciate you being here. Mr. DiLullo, go Army. Thank you. I started my career in the Army as a grunt, attached to an infantry unit as a forward observer, and then ended up going to flight school as a warrant officer. So I never did the academy or anything like that. I'm not quite as smart as you are, but appreciate you being here nonetheless, and always appreciate a good Army infantryman. So thank you. And you wore your Army blue tie, infantry blue tie today, I could tell, and appreciate the rest of you for joining us as well. Had a question for Dr. Bloom. With the issue of diabetes and the chronic nature of handling that disease, and especially the prominence it has within the veteran community, I don't think any American can turn their head today without these GLP-1 advertisements smacking us in the face every time you turn on the TV, open your phone, use anything. Is that a promising preventative from some of the disease progression with diabetes? And can you give us any insight as to where that might lead going forward?
Well, I think it's the data coming out is actually quite dramatic. So the potential for these medications, it could be considerable. I think we still, though, have some challenges. Like if you look at the other major blockbusters, ACE inhibitors, ARBs, statin therapy, we're still not seeing these medications, and these are pennies, to being utilized by the patients who really need it most. And now we come back to the GLP-1s, which are often injectables. So I think we're going to have to still figure out ways to make sure that the patients who need it most can get them, because often it's not necessarily a challenge. It's a challenge of access. Can they get those medications and use them? But I think their promise could be considerable.
And then it sounds like from each of you describing the ounce of prevention versus the pound of cure and the potency and in reality of which that provides us better patient outcomes, preventing disease progression, finding things more easily and quickly, and allowing us to treat those conditions that lead to a cost savings as well as a better patient outcome for the people that we are treating. I have the privilege, I will say, Mr. Chairman, not the curse of chairing the subcommittee dealing with this electronic health record update, but the privilege of chairing that subcommittee, and we've taken testimony about some of the challenges related to that. But one of the hopes I have is that we can cut down on the inconsistent nature of maybe duplicating expensive screenings, expensive testing that's done, and use of equipment. Appreciate the work that Philips does in a lot of this technology that's out there, but these are expensive tests that can be done. Do you have any insight into bringing that together to achieve a better cost savings for us around the duplicative, cutting out the duplicative nature of some of the testing, whether veterans are getting their treatment entirely within the VA or in combination with an outside, civilian medical treatment, for example.
Maybe to start, Congressman, thank you. It's a complicated question, but I think if you look at some of the specific technology around, so EHR, by definition, we work at the software level and at the product level, we work interoperably with any EHRs out there. That's, by definition, we should never have a vendor with, with the VA that isn't interoperable across networks. Now, the challenge specifically with EHR is it connected to community care networks as well, because today a lot of times that's a flat file and it's not really a fully enriched product for
You mean like editable, or the data is
just flat.
usable? It's almost like a faxed packet that's put into a PDF file.
So today, for radiology exams or what we call PACS systems or archival and communication systems for images for veterans within the VA, Philips has about 50% of that overall business within the VA with the different Vista applications, but they are highly unique or customized. So in moving to a standardized central or enterprise level EHR, we have the opportunity to integrate all of those different instances into one. So we're already in the VA, and I think it's an opportunity to say, hey, we can save a lot of money by trying, instead of doing something new, we just integrate the interoperable nature of our archival and retrieval systems already holding millions of veteran records.
Okay, thank you. And my time's running out, so certainly appreciate each of you. If you have insight into how this is going, would appreciate the opportunity to hear feedback from you on that, either privately or otherwise. So thank you again. Mr. Chairman, yield back. Thank you.
Thank you. Representative Sheflett-McCormick, you are recognized for 5 minutes.
Thank you so much, Chairman Voss, and thank you so much to our witnesses for being here. I'm very disappointed that we do not have anybody here from the VA. The reason being is, before I came to Congress, I was the CEO of a home health care company for 15 years. And I'm very well aware of your products and how great your innovation has been, especially when it comes to reducing readmission rates, where it comes to identifying real-time health issues and providing it to the providers, but also prevention. And I don't believe that you can't do prevention and treat critical care at the same time. But it does take the right structure, it takes the right policy, and it also takes the right personnel in place to make sure that all of your technologies are successful. None of your technologies are self-sufficient, meaning that they don't work by themselves. They have to go to a healthcare professional, a clinical care professional. In understanding that, it's important that we have the VA here to actually talk about the systems they have in place, to talk about the policy and the procedures they have in place. Without them being here, there's no substantial certainty that your products can actually help our veterans in its sole entirety. And so my question is going to have to be to you guys, which I appreciate you taking these questions. Do you believe in this current environment and the cuts that we see that are going on, that the VA has been able to take the proper steps to set up the proper structure, process, and personnel to ensure our veterans get the same care or similar care as our private insurance patients? That could be for any one of you.
Congresswoman, it's again, a wonderful and complicated question, and so I'll take a stab at it from our perspective. The first thing to think about, I believe I've been doing not just technology deployments at Philips, but for my entire career since the military. It is incredibly complicated, and change management and personal change is the biggest and hardest driver to really overcome to get the full adoption of that capability. At Philips, for example, when we come to the VA, if we have a new software or application, because we're much more into the workflow of how the VA clinicians operate, not just the box itself or the piece of technology, it's about the workflow. So when we do that, we bring our clinical specialists in during deployment, after deployment, to try to get the maximum use of the capabilities that we deploy. We also have over 1,300 education platforms, either on-demand seminar or on-site or physical trainings that we can deliver during the life cycle of that project. We work that into our contracts with the VA because we also understand there is human turnover. So in every aspect, we understand it's hard. We can't necessarily cover the people that are coming into the VA, but we can make sure that we have all the adoption, training, and capability delivery to them during the entire life cycle of the product within the VA.
So I guess my question, just to make it short, would be a yes or a no. Do you believe, or are you substantially confident that the VA actually has the process in place to ensure our veterans will get the best outcomes? Without the VA being here, they can't answer, so I would pose that to you guys. I know it's a difficult.
I could not answer for the VA, maybe one of you want to, but I would suggest that we work very hard as part of the process in deployment to work that out with the VA on those specific applications.
Now, last session, I was the ranking member for technology and modernization. And after several hearings, it became very clear that the VA did not have the structure in place, nor the process or the personnel to ensure that their implementation was successful. And so that's why I had to come to you, because what we're looking at right now is a standard of care that our veterans are actually being denied. And they're being denied because the VA is not living up to it. And I just want to, reiterate that we can actually treat our veterans who are in critical situations while simultaneously preventing other disease and preventing and seeing our veterans do better. Most importantly, we've even seen that when you have these remote monitoring devices in their homes and you have personnel, that the entire family has done better. So not just the veterans, the caregiver, the spouses, and the children. So it's important that we hold the VA to task and that the VA be invited and is present to make sure that we're all living up to our promise to our veterans. And so my last question would be, do you believe that you actually have the resources? Once again, I know it's hard for everyone to answer this, but now let's look at the resources for prevention. Do you believe that you have the resources, or do you believe that there can be investments into ensuring that we are dealing with prevention?
I do think many sites, thank you for the question, by the way. Many sites do still struggle. Do they have enough staffing to be able to do preventative care? I think a lot of it just comes back to even the incentive structure, making sure that they can incentivize preventative care, because many of them find that it's not as viable. They're going to need to stay on doing the adequate workload that it's going to take to keep them in good standing. So I think there's a lot to that, making sure they have the staffing, but one key piece is just making sure that they're able to protect their time towards the services that they need to do the most.
Thank you. I yield back.
Representative Hamdan.
Thank you, Chairman Boz, for convening this important hearing today. Now, as many are aware, Arizona is emerging as a prominent technology hub, especially as states like California implement regulations that hinder American innovation. I have an interest in biomedical innovation and its broader implications, and I appreciate the opportunity to engage in this critical discussion. Now, currently, the procurement process within the VA system places the agency at a significant disadvantage, often delaying access to the latest technological advancements by 2 years. This means that by the time the VA acquires a life-saving innovation, private hospitals across the nation have already utilized it for an extended period of time. Furthermore, by the time the VA implements technology that was initiated for purchase 2 years ago, it is often outdated. Now, in my opinion, the dedicated men and women who served our country deserve better access to cutting-edge solutions, and the medical staff at VA deserve better, more modern tools to deliver that care. Now, my first question is to you, Mr. DiLullo, and thank you for your service, and thank you for your daughter's continuing that legacy in her service as well. You must be very proud. Now, I noted in your written testimony the section regarding rate, or the rapid analysis of threat exposure. Now, this technology piqued my interest, particularly given my role in the House Armed Services Committee and your mention of Phillips collaborating with the Department of Defense on rate. Now, could you elaborate for my colleagues on what rate is, how it operates, and its practical applications?
Thank you, Congressman, for the question. I'd love to talk about this because it's a force protection measure for me, and it's about friends that I have that are serving on the front lines in other places in the world that they're using this today. So rate, rapid analysis of threat exposure, basically years ago we started with the Defense Innovation Unit. It takes commercially available devices like this ring that I have on and this watch that I have on that can record, and other devices as well that are commercially available, that you can extract about 165 biomarkers, whether it's heart rate, stress level, sleep level, oxygen level, temperature. We've been building algorithms with the DoD for years as a force protection measure to determine when an individual might have a degraded state. Where this becomes particularly applicable in over years of building thousands of servicemen and women's data, we've been able to apply algorithms that allow us to determine whether someone will come down with an infection within inside of 48 hours or outside of 48 hours from actually showing symptoms. So imagine you're on an aircraft carrier and you have an infection that you haven't shown symptoms yet for a day or two. I can actually intervene and quarantine you and keep the force safe and keep the mission going. We would love to see that kind of speed and innovation working with the VA as well, because we see applications with healthcare providers within the VA, a critical resource and a constrained staff to make sure that if they are about to contract an illness, that they're not, A, passing that on potentially to another veteran that comes into a VA center, or that we see a degradation that makes them vulnerable in an ill population, that we can avoid that and keep them safe and working another day.
Very good. So that's a pilot program, you said?
So we ran a pilot. It's 11,000 participants, men and women in the armed forces that are doing this pilot, even some Navy Academy midshipmen, I believe, much to my dismay. And still, we find the algorithms are trainable and learnable to new solutions and new infections constantly as we're building this pilot.
Will it be expanded?
We are working, we would love to continue the discussions with the VA to expand this into the VHA system as well, yes.
Very good. And the privacy considerations on that is being taken into consideration as well, correct?
It is complete, it's commercially available applications, but we secure that obviously and democratize or sterilize the data, so it's really looking at human condition, it's not looking at any individual or personal applicable data, personal health information.
Very good. Now, Dr. Parthasarathy, welcome from Arizona and my alma mater for law school. Now, how has the University of Arizona used artificial intelligence to enhance patient care?
Yeah, we've been able to embed that into the electronic medical record system. And so that, for example, for sleep apnea, we run algorithms that have been developed by researchers at MIT to be able to identify and alert the clinician, the provider, the nurse, or the nurse practitioner at the very busy clinic that their patient may, for example, have sleep apnea. So, and that way they're able to be alerted to the fact that this is essentially a disease that can be diagnosed, treated, and therefore keep patients out of the hospital and reduce the risk for heart attacks, strokes, and so on and so forth. Secondly, we are developing algorithms to help them be more adherent to the treatment. Because just because there's a medication doesn't mean they're going to, or a device therapy doesn't mean that they're going to use it. So this is meant to actually be patient-facing technology that actually gives them psychological cues and advice and tips and tricks for them to be able to use the CPAP device, for example, for sleep apnea in a more adherent fashion. So we're actually collaborating with researchers at Harvard to actually develop an algorithm for us to be able to use that to help augment the ability for people to be able to use the therapies and improve. Similarly, there's actually an FDA-approved technology using algorithms embedded in an app that is helping deliver cognitive behavioral therapy for insomnia that can actually help bend the curve on insomnia or address jet lag for active duty military, for them to be able to adjust their sleep time before they travel across time zones. So there are various technological approaches, and we are being able to embrace some of them, and some of them are in development. And one particular one that I'd mentioned earlier was this Vermona technique that has been developed at the University of Arizona with funding from the Department of Defense that is looking at virtual imagery. It's almost mimicking a video game of shoot, no shoot situations to be able to test the neuropsychological decision-making of the individual. And it's being tested in 1,000 individuals who've been at the war theater in order for us to be able to address whether a 20-minute video game can replace 4 hours of a neurocognitive battery.
Very good. My time is up. I yield back.
Representative Pazensky, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Ranking Member Takano, for convening this hearing, and thank you to our witnesses for being here today. I appreciate the pursuit of innovative technologies that help deliver world-class healthcare to our veterans, a goal I think everyone in this room does share. However, I too am deeply concerned that the Trump administration and Secretary Collins are rapidly dismantling the VA workforce, threatening VA's healthcare operations. And I've been listening to veterans back home. I hosted an event with Senator Duckworth and our local VFW and American Legion chapters in my district just this last Sunday. And we also met with the Tri-State Women Warriors Network just yesterday. I listened to veterans sharing stories of friends who have committed suicide, veterans who rely on the VA every day and asking me about who has been laid off and why. There are questions like those that I cannot answer because those are questions this administration itself can't answer. When the VA itself is headed to a crisis, why are we having a discussion about biotech? Without VA present, this hearing is a missed opportunity to look at VA's capacity, at the staffing and resources needed to deliver care, to improve VA's procurement systems, to modernize VA's physical and software infrastructure. Without the VA witness here, we cannot get answers to the administration's recent actions on crucial VA research. Instead of building on the VA's tradition of innovative research, this administration has set us back by firing researchers and targeting research with quote-unquote trigger words such as female, women, and gender. As Ranking Member Takano noted in his remarks, VA research findings have contributed to not only saved lives, but also greater profits for companies like Philips and Boston Scientific. Innovation is not limited to the Veterans Health Administration. As ranking member of the Technology and Modernization Subcommittee, I'm also deeply concerned that the cuts to the VA Office of Information and Technology staffing and budget will disrupt VA's IT modernization efforts. The VA is still operating with outdated technology to manage its medical equipment inventory. For example, the Automated Engineering Management System Medical Equipment Reporting System, a system built back in the 1980s, is not able to support today's interconnected software-based technology. It seems tone-deaf to engage in conversations about innovative biomedical equipment when the foundations of the VA are crumbling. When the VA is threatening to cut 80,000 of the mission-driven staff who serve veterans each day, when Veterans Crisis Line operators say DOGE has made their job stressful to the point of tears, being forced to do more with less while remaining steadfast in their mission of serving veterans in crisis, when VA clinical trials have been delayed or canceled because the staff who managed them were let go, when VA has canceled hundreds of contracts, including IT and management contracts, among others that will impact cancer care and VA's ability to access toxic exposure and disability ratings, when President Trump's latest executive order attempts to intimidate federal workers out of their unions and attack collective bargaining rights, including for over 425,000 veterans across the government. To our witnesses here today, I do truly appreciate your work, the work you're doing to improve the care for our veterans, and I wish the VA could have joined you today to be a part of this important discussion. My question is for Mr. DiLullo. Do you know how many non-clinical staff members are required to install, inspect, maintain, and repair your products?
Congresswoman, I appreciate the question, and I actually don't know that. I would be happy to follow up and have a discussion separately.
That would be great.
Both our side and the VA. As I mentioned earlier in a statement, one of the things that we do is we dedicate resources to the VA specifically for adoption and maintenance. And so we look at that in a geographic context. We have people that show up at VA centers and help with that continuing education, but we also help maintain the equipment.
That would be really wonderful, because one of the things I understand the administration has been saying is that these layoffs are not going to, or only are going to be held off in, for folks that are doctors or nurses, but the non-clinical staff are also very critical to making sure that the mission of the VA is complete and conducted for our veterans. So I would very much appreciate that. Thank you, and I think I'm about out of time, so I yield back.
Thank you. Representative Radwagen, you are recognized for 5 minutes.
Thank you, Chairman Bost and Ranking Member Takano, for holding this hearing today. Talofa, and thank you to the witnesses for your testimony. Dr. Parthasarathy, thank you for that extensive answer earlier on sleep apnea. What are the consequences of some of the consequences of sleep apnea if left untreated, and what is sleep apnea therapy non-adherence?
Thank you. So sleep apnea is when individuals have repetitive obstruction of the upper airway and it causes low oxygen count, and as a result, that reduces the amount of oxygen that goes to the heart and the brain and leads to increased risk of strokes, heart attacks, heart failure, motor vehicle accidents, also reduces the rate of healing of traumatic brain injury, and can also lead to depression and anxiety. And so these are all the consequences of untreated sleep apnea. It can also lead to increased amount of hospitalizations, and also there's an increase in all-cause mortality, death due to any cause, if left undiagnosed and untreated. And the problem with adherence is that the therapies usually involve a CPAP mask that's applied on the nose with pressurized air, and people find it difficult for them to wear and get used to. As a result, variably, about 2/3 of people only are adherent, or in some communities, it's only half of the individuals that are adherent to the CPAP therapy. And we have shown, other researchers have shown that non-adherence to the treatment can actually lead to increased risk for all of the consequences that I enumerated previously. So it's very important to have these treatment approaches, and now the new GLP-1 drugs, which are used for diabetes management, has also been shown to be effective in treating sleep apnea, and not just devices. But again, people are not necessarily adherent to medications or devices, and as a result, we need to do more to use these medications and devices. As Everett C. Koop, the Surgeon General, said, pills don't work if people don't take them. And so devices don't work if people don't use them. And so I think that's a very profound but very simple statement. And that's where we did our research, where veterans were actually helping veterans through a peer-to-peer intervention to help promote their importance of using it and to make them realize by talking veteran to veteran about the importance of using these treatments in order to get the full benefit from the therapy that has been delivered to us.
So is VA equipped to monitor patients' adherence to sleep apnea therapy?
Yes, they are. And many of these devices have a centralized, secure, safe harbor system that has PHI protected health information in it, but it's also held in a secure manner, where these devices in people's homes transpons and sends it through the cell phone tower information about the usage and non-usage.
Thank you, Doctor. Let's see. So there were a couple of questions earlier about diabetes, and Dr. Bloom, what are some of the causes of diabetic foot ulcers, and what are the consequences of diabetic foot ulcers if left untreated?
Thank you, Congresswoman, for the question. And by the way, we should acknowledge some of the unique challenges I think you see for the constituents you have. My understanding is that podiatric care comes from the Honolulu VA Medical Center, and that this podiatrist has to come out only once a month to see patients, right? The opportunity is to catch problems in between those visits. And so systems that can offer, expand monitoring passively hold, I think, a lot of promise there. The causes of diabetic foot ulcer, there's a number of them. One is you have diminished blood flow into the limbs, so you can't really bring all the healthy mediators and healing cells to a wound. You don't have enough oxygen to that tissue, so it's already acting dysfunctional. The nerves get destroyed, so now you can't feel any pain, the gift of pain. You could get injured. Now you don't know that that wound is there. Because of the high glucose, you can get really bad bugs when they get infections, like mucor, Pseudomonas, some of the bad staph infections. It's basically a perfect storm to get now an ischemic wound, low blood flow, infected, that we now need to see me in the operating room.
So is it faster for VA to monitor a veteran's health by using a Podimetrics mat at home or by scheduling appointments at the office?
The hope is they don't need to come into the office. Yeah, give them a mat in the home. They can step on it for 20 seconds a day while they're brushing their teeth. And now our hope is to avoid the need to ever come into the facility in the first place.
Thank you, Mr. Chairman. I yield back.
Representative McGarvey.
Thank you, Mr. Chairman. And look, I'm excited about today's hearing. I think this is an amazing opportunity, truly an amazing opportunity to ensure that the VA is the leader in innovation so that we're giving the best care to our veterans. I think about what the Department of Defense looks like. They had the Defense Advanced Research Projects Agency that I think everybody knows stands for DARPA. They incentivized innovation. And because of that, we have things like GPS. We have the internet. Not only are they helping our soldiers on the battlefield and giving us a technological edge, they are then technologies that all of us can use. What if we did the same thing in the VA? What if we actually incentivized innovation? Think about what the VA is, 9 million patients, the largest patient population by a multiple. 75% of physicians do some of their training at the VA. We have the largest longitudinal data set of any healthcare system in the country. We get you when you're 18, sometimes we keep you till the day you die. And what are we doing with this? What today's hearing shows me is not enough, but that's what's exciting. Because we can do this. We've seen models of this that work. And think about what DARPA did. Now think about it in the VA context. If we find a cure for traumatic brain injuries, for PTSD, for spinal cord injuries, for our veterans, we do it for everybody. But those are service-connected injuries. What happens if the veteran who comes in with diabetes or Parkinson's or heart disease or cancer, and we find a cure for that? I think this is a both and proposition, that the balance for this is through partnership, where the VA and industry develop solutions collaboratively that ultimately save money, generate revenue, and provide better healthcare for our veterans. So I would love to see this. And Dr. Bloom, I think your story is a perfect example of the kind of innovation possible at the Veterans Health Administration. In your case, CARES Act funding made it possible as a highly effective pilot project for monitoring diabetic foot ulcers. But the VA's traditional acquisition structure doesn't really allow for this kind of innovation, does it?
No, sir. Thank you for the question. You know, what I have to acknowledge is that so when you're starting your company off and you have a mission, a vision you want to accomplish, you need to go to the venture capitalists to fund this company. It's a big part of getting it up to speed. The plain fact is that every VC I went to, when I said I was going to go to the VA, often they would even roll their eyes. I was dead in water. Now, the reason why they did that is they actually cited a number of companies that they had funded that commercialized through the VA, and they were all dead. Right? So this was no longer a winning proposition for them. So if you actually could have something like an advanced market commitment that actually say, look, here's a critical problem the VA is saying that they have, and they are eager to buy this type of solution. Go into a venture capitalist with that type of some sort of commitment by the VA. That's company changing. That's healthcare changing, right? It's the startups that take this enormous risk. We can put hundreds of millions into a system. Like, government isn't set up to take that kind of risk, and even larger companies can't take that, but we can. But without that funding, we're dead in water.
Yeah, and I'm glad you brought that up, because last year, at the very end of last Congress, I introduced a bill called the Innovate Act, hoping to empower the VA with the authorities it needs to conceive of and scale up these type of innovative solutions you're talking about. I plan on reintroducing a newer version of that bill this time. The bill's not going to it will support, not replace, the outstanding research and innovations already underway inside the VA. But of course, it's going to do things that, like you talked about, it'll provide VA with two specific authorities that would make these partnerships and pilots possible: the Other Transaction Authority and the Advanced Market Commitment that you talked about. And just to break that down, you know that Other Transaction Authority is a special authority that lets government agencies team up with outside organizations more quickly and flexibly. That's a big help that you just mentioned. And the Advanced Market Commitment, it's like a promise from an agency to buy a product in the future, even if it hasn't been created yet. This encourages companies to invest in developing solutions they might not otherwise pursue. And of course, you know, this approach led to the creation of the pneumococcal vaccine, which has saved over 700,000 lives in developing countries. I think we have to do more. I think we have to do more of this type of work where we're collaborating to help our veterans. And I will say, there is government spending and there's government investment, and we are investing in these preventative medicines. We are investing in these cures and these innovations. We are not just helping our veterans, we are helping everyone. And I think doing the mission of this committee. Dr. Bloom, I appreciate your testimony. Mr. Chairman, I yield back.
Thank you. Dr. Miller-Meeks, you're recognized for 5 minutes.
Thank you very much, Chairman Bost, for this hearing. I thank our witnesses for being here. 2 years ago, I was asked to chair a task force for my colleagues on modernization of healthcare, looking at what we could prepare for legislation. And I actually focused that on three things, and that was access, prevention, and affordability through artificial intelligence, technology, wearable devices. And I think what you've underscored today is exactly that. Is it possible, and I'll ask you all this just very quickly if you can answer, is technology disruptive? And sometimes as we advance, whether it's from an agrarian society to the industrial age to the information age, are there people who lose jobs and positions? Mr. Gray?
Just like during the agrarian time there is, but they will flex and new jobs will be created.
Dr. Bloom?
Your hope is you're going to be able to avoid the need for a number of clinicians, but those can be put to other use.
Mr. DiLullo?
I believe technology available today allows clinicians to work at the top of their licensure, which will help us scale.
Dr. Parthasarathy?
I think that this is where implementation science needs to be followed, where it needs to be phased in rather than be disruptive.
So not unusual that as technology advances, we will, 1, have more access, 2, be able to use prevention, 3, make it more affordable, and we may need less people to do certain things, such as 80,000 VA employees that were hired during the last 4 years at a $126 billion increase in revenue to the VA with level national people applying for and receiving care. So I think that that's a normal process as we develop and grow and innovate. Dr. Blum, I think Representative Radewagen asked you about the causes of diabetic ulcers. As a doc, I know them, but if you could, and I think you mentioned this, consequences of diabetic foot ulcers left untreated or poorly treated, and you mentioned amputations and the cost of amputations. So could you just reiterate that again?
Well, first, per VA national data, we know that the 5-year mortality of just getting the foot ulcer is 70%. That's worse than almost all cancers except for maybe glioblastoma, pancreatic cancer, a couple of the really big scary ones. So that already is very alarming. And of course, if they get infected, they might have to see one of us in the operating room. Now we're going to lose the limb, and that's now a life-altering event where they now can't take care of themselves the same way. We see dramatic increases in depression, suicide ideation, the actual suicide event. It's a devastating change in their life. For example, we had one patient where they just stopped using it. Now, per protocol, we're going to reach out to that patient and try to find out what's happening, remind them to get on the mat, and we had to just leave a voicemail. They called back the next day, thankfully they did, and acknowledged that the pain was too much in his limb. He now wants to take his life, thanked us for the care that he had, and just wanted to let us know that that was going to be the case. And thankfully, we were able to get him the services. But
So it's because of those things that products like yours have recognized significant cost savings as well as quality of life improvement.
significant savings, and now for that veteran, he's still with us, just thanks to that extra touch to the patient.
And how was your experience engaging with the Office of Health Innovation and Learning at the VA?
Well, I think that the innovation group offers like this critical part to the industry. And when we were just coming along, we didn't know what we were doing. There's no manual to the VA. Try to come in any way you can. When we started to work with it had a different name prior, but OHIL essentially, they were able to figure out, okay, what is the right model for a company to adapt to the VA? It's arrogance to presume the VA is going to adapt and bend to us. So we had to build it together. But when we did, now it was perfect built for a veteran. Perfect built for those VA infrastructures, and that's why we're seeing the savings we are.
Thank you. And I'm running out of time, but Mr. DiLullo, what complementary steps do remote services offer to connect VA practitioners with rural veterans and may save visits to the hospital or to practitioners?
Congresswoman Miller-Meigs, it's great to finally meet you. I would actually, I'll use one example that's is significant in our ability to reach into rural communities specifically. We have something called a Lumify, which if you can imagine an ultrasound today, an ultrasound can be done on an iPad. They can have a transducer plugged in. I can video in on broadband a technician or a sonographer or a radiologist remotely anywhere. For example, I was in the Kalispell Clinic in Montana this summer. They have no imaging equipment there, but yet it's a large enough facility where you could put an iPad in there and beam in somebody from Fort Harrison from 3 hours away, and I can get a gastro scan, I can get a prostate scan, I can get a liver scan with over-the-shoulder coaching and in real-time results. I can do that anywhere in the country, and we do that in private health care.
And have you used artificial intelligence to enhance patient care?
Absolutely. I'll just use that. We could talk for a long time on the ability to enhance imaging and speed the process, but in that particular case, we actually construct the image in AI on the system itself and render a very precise diagnostic. And that's our new opportunities, not just to reach patients, but give precise diagnostics quickly.
Thank you. Representative Ramirez, you're recognized for 5 minutes.
Thank you, Chairman, from the great state of Illinois. I want to thank the chairman, the ranking member for holding today's meeting, and I want to also thank all of the witnesses that are here today. Today's committee hearing is titled Harnessing Biomedical Innovation, Modernizing VA Healthcare for the Future. And I want to start by putting on the record that I find it difficult to have this conversation, an important one, right, on innovation, without having the VA here. That's not your fault. You can represent the VA or ask them to be here. But in absence of them being here, it means that we're having this robust conversation about technologies and innovation, how to modernize the VA healthcare without the same agency, the very same agency that would be responsible for these implementations. And so it almost feels like a sales pitch instead of real conversation about how we modernize the VA in order to provide the highest quality of care for our veterans. It feels like a calculated attempt, not by you, but in the way that this committee was set up in this hearing, to accelerate privatizing the VA while padding the pockets of for-profit companies. All it feels like to carry out a must-Trump agenda to dismantle the VA under the guise of modernization and efficiency. Look, the Musk bad boss playbook is manufacture failure through hiring freezes, mass firings, and reduction in resources, scare and demean the workforce, disregard the clients, publicize every single problem, all so you can say, see, it didn't work all along, and then venture capital and corporations can swoop in and claim their only solution left to try is theirs. And we've all seen how that ends up. Have we not learned from X, formerly Twitter? Just last month, Trump turned the White House lawn into a Tesla showroom after announcing that he planned to buy a Tesla himself. See, there's a pattern. Use federal power to boost private industry, and this time at the expense of our veterans. And look, I do believe that veterans deserve the highest tech and devices possible, but our veterans need the state-of-the-art high-tech devices with fully funded, fully staffed VAs that can actually implement these devices and these technologies. Now, how do you do that if you don't have the staff to be able to operate them? Mr. DiLullo, you lead a team of nearly about 17,000 employees, am I right? Okay. So if 15% of your workforce, if my math is right, that's about 2,550 employees, were cut, could you operate effectively? Yes or no?
Congresswoman, that is not a yes or no question, but I would tell you it would be harder. But I would also treat it as a compelling event to find ways to deploy technology to make up or automate things that I don't want people doing anyway.
But if you didn't need those 2,550 employees, then why would you hire them? See, given VA's planned reduction of 83,000 employees, how do you expect the VA to implement and sustain new technologies your company's providing?
Congresswoman, let me address it from my perspective only. I have no insight into the VA or the...
And they're not here, so
policy
they can't
positions.
answer.
But I would say from my perspective, everything that we're doing, and we talk to the VA about, as well as every other health system in the country, three things are true. Everyone is seeing an increase in needed care. So people are getting older, more people are getting older, they need living longer, they need more care. Second thing is, cost of care is going up. 17% of GDP in the United States is spent essentially around healthcare, which is an astronomical figure, but it means cost for the average American, to include veterans, goes up. And the third thing is that staffing is going down. People are not entering the medical field at the rate they're leaving. So this is not a VA-specific item. It is a national crisis, in my opinion. And so technology companies like Philips and like the other ones here are trying to find ways to create automation, AI-enabled solutions to do much faster diagnostics.
Thank you, Mr. DiLullo. I'm low on time, so I really appreciate what you just said, and I absolutely agree with you. We need that innovation. We understand the challenges that we're living, but given the dramatic staffing reductions in the VA, it's hard for me to believe that the VA will have the capacity necessary to introduce Philips technology and ensure that there's proper maintenance, operation, and the effective use of these systems. And so, I asked you the questions I did, recognizing you can't speak on behalf of the VA, but unfortunately there's no one here that can. And I'm asking because they weren't invited to appear before this committee. And so, in your opinion, wouldn't these be better questions for the VA leadership, who could provide real insight into the workforce capacity, the budget constraints, and the operational readiness to be able to operate these devices?
Congresswoman, in my opinion, no single entity or healthcare provider can solve those things in a vacuum. I think it takes partnership and open discussion with partners that bring capability.
Thank you, Mr. DiLullo. My time is up. I would like to have the VA here to answer these questions. With that, I yield back.
Thank you. Before I go to the next speaker, I want to respond to some things. Let's be clear. There's no final number of any potential reduction in workforce. None. What we do know is that unlike the previous administration, Secretary Collins and the VA have been transparent with Congress every step of the way, and I expect to continue moving forward. But this idea that we should start ringing the alarm bell before the plan even exists, that's just more of the same fear tactics and political threats. If you want to have a serious conversation about oversight, I'm here for it. But let's not sit here and pretend there's a 5-alarm fire when we're still looking at the blueprint. Veterans deserve the truth, and I just want to make sure that you understand that's the truth. So let's get back to the discussion here at hand, and with that, I yield to General Berkman for 5 minutes.
It's interesting to observe life. I was just sitting here reflecting on 20 years ago, being at that witness table in uniform before a military personnel subcommittee hearing. There were 7 reserve and guard chiefs, and we were pretty underwhelmed by what happened and what was discussed up here. I would associate my comments with the chairman. Let's not waste time, because veterans never wasted their time because of the fact that they fought to defend our country. So we'll get right to the meat of it right away. And just, yeah, I was in the Marines a few years, but probably most important for this discussion here was for 3 decades, I was involved in the operating room equipment business, a lot of it in radiology, some in microsurgery and others. So I'll kind of put that hat on a little bit here. But let's get right to the questions. Mr. Gray, your testimony states that approximately 61% of all AFib procedures in civilian hospitals will use pulsed field ablation technology, yet only roughly 10% of VA hospitals have access to this technology. Why?
Yes, sir. Multifactorial, but really for the past year. So this was launched by the FDA in March of 24, and there was a huge scramble for the technology, so it was so transformational. I would say because of the budget uncertainty within the medical facilities in the VA, not across the VA, but each one, they weren't sure if they were going to have the budget, when it was going to come. Should they not make a purchase because they're not sure if they're going to have the infrastructure in place? It was almost this fog of war type of mentality, so it was almost like stasis going on. So that was a huge part of it. The second one is what I talked about before with the prosthetics contract. There is not today a process in place to add new products like there is in the MedSurg Prime vendor. So you have to jump through so many steps, and if you don't hit every single step, and there's not money there, it's just a very, very challenging process. And so while we're able to get some other new technology like that agent drug-coated balloon into the MedSurg Prime vendor program quickly, the prosthetics contract was just much more challenging. And that's the biggest issue. Again, we have it in less than 10 hospitals, and physicians are clamoring for it because, as you said, it's becoming the standard of care for atrial fibrillation in the United States, really across the globe.
Yeah, well, it's utilizing new technology that's been developed, tested, and getting it into the VA system as appropriately quickly as possible to provide better outcomes for the veterans.
Yes, sir.
Okay.
It's 40% faster, and it's safer than the current technology. We have to get it in there.
Well, just a little data point. Several of the surgical instruments used today were invented in the 1700s, but that doesn't involve electricity or computer programming. And how important, to get back to the point here, how important is the clinical input, speaking of instrumentation and medical equipment, how important is clinical input in the medical procurement process? The people who will actually be using that equipment in the OR, in the radiology lab, in wherever it is, how important is that clinical input?
It's critical, it's necessary, whether it's the VA or it's a commercial civilian hospital, physician voice has to be part of the process. And when they are, the process runs smoother for the hospital, for the system, and for the patients.
Yeah, so the point is include the people using it in the decision process.
Absolutely.
Since I serve on both Armed Services and Veterans Affairs, how does VA compare to DoD when it comes to the procurement of medical technology, especially when it comes to timelines for implementation?
It's a difficult question to answer because it's not an easy question to answer. I would say this, the DoD has a contract vehicle called the ECAT, Electronic Catalog, that's fantastic. Once you get a product, you submit the right information, it goes live pretty quickly. Almost identical to the MedSurg Prime vendor contract that you worked on in the VA. So very similar. But then you also have the prosthetics contract in the VA, which needs to catch up to the other two. So it's a long answer to say the DoD and the ECAT is as good as the MedSurg prime vendor in the VA, but the prosthetics contract is much lower and needs to get up to that level.
So to cap off, because I see I got 30 seconds left, it is okay and desirable, I would suggest to you, within, just compare the DoD and VA, to allow them to piggyback off of and take each other's successes and build on it rather than reinvent the wheel in two different departments. So let's leverage what we have and let's move forward with good processes. And with that, I yield back.
Representative Dexter, you're recognized for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here. As I understand it, the purpose of today's hearing is to examine how our veterans can access the high-quality care that they deserve while ensuring the VA remains a responsible steward of taxpayer dollars. Absolutely an appropriate goal for this committee. Given that goal, I was shocked in preparing for this hearing to learn that the majority had declined to invite anyone from the VA to testify. As a pulmonary and critical care physician, I was involved in specialty-relevant procurement processes. I know very well what a robust procurement process looks like. And this isn't it. I'm frankly horrified that we are here having a discussion about important clinical decisions without any clinicians. And no offense to my colleagues, but not a single one of us should be engaged in this. We have procurement processes. And if it isn't working optimally, let's focus on fixing it. That is absolutely the right thing, not go around it. This right here today is how we increase risk for waste, fraud, and abuse. I'm completely unclear on how having a series of industry-adjacent representatives here today without the insight of a procurement discussion advances the goals of using taxpayer dollars wisely. As someone who served as a VA provider for 7 years and as a US Congresswoman, I care deeply about providing our veterans with the best possible care. But that is not what this hearing is about. Instead, we have decided to use, my Republican colleagues have decided to use the incredibly valuable time and resources of this committee to give private industry an opportunity to pitch their products. At the same time, we are doing extraordinary harm to our systems of medical research and development that has historically been a priority for the VA. I'm just going to use one example, and I mean no disrespect. I just want to go through this for the purposes of illustration. So, Mr. Gray, I read your testimony regarding Farapulse. And in your written testimony prepared for today's hearing, is it true that you cited the study entitled, quote, pulsed field or conventional thermal ablation for paroxysmal atrial fibrillation to substantiate the value of this product?
Yes, I believe so.
Thank you, Mr. Gray. Is it also true that the study draws its conclusions from a non-inferiority trial?
I believe so.
Thank you. Finally, did I read correctly that the study was financed by Boston Scientific?
I think so.
For those listening today, it's important to note that this study, financed by the company who manufactures the product, and which showed only that it is no worse than other treatments on the market, is the only evidence that was provided by our witness. And again, this is not the right place to do this, so I'm not trying to call you out specifically. It's just that it's not the right process. We do not have access to the cost data to be able to compare it to current practice that is not inferior. And the VA has a procurement process that we are not discussing here, and we should be. If that process isn't working as we've heard it is not optimally, then it is our obligation to help it do better. Although President Trump and the architects of Project 2025 claim to support a veteran-centric VA system, it is clear yet again that the rhetoric does not match reality. Instead, my Republican colleagues seem more interested in furthering corporate interests than truly serving the veterans who fought for our country. Where is the VA today? Where are the clinicians who can talk about the impact of the hiring freeze or the terminations on veteran care, or even whether or not they think these are good products to use? And why in the world are we, politicians, being involved in this procurement process? Maybe even just a sales pitch that should be evaluated by a rigorous, reliable process, not a partisan body powered by special interest investments. The absurdity of today's hearing is honestly quite stunning. I want to see a VA that fulfills its promise to our veterans and their families, one that is efficient, and innovative, expands care to veterans most in need, and focuses on prevention, as many of you do. However, instead of focusing on that, we have listened to advertisements without hearing from the VA or the clinicians who will use these products, engaging in a forward-looking conversation about how to best use taxpayer dollars. That is what this committee should be focused on. That would be living up to our promise to our veterans. That would truly be veteran-centric. This hearing is a distraction from the harm being done to veterans across our country. We need to all be prioritizing their well-being, not corporate interests being discussed here today. I implore my colleagues to do better. And thank you. I yield back, Mr. Chair.
Representative Siscomani, you're recognized for 5 minutes.
Thank you, Mr. Chairman. You know, my views on healthcare are pretty simple. No matter where a veteran seeks care, they should have the highest quality outcomes and the most efficient ones as well. I was proud to sponsor legislation that was signed into law to focus on support for at-home care services for our veterans and their caregivers. I want all options to be great options. This is what it truly means to have our veterans at the center of our mission in this committee. I also want to, before I get into my question, specifically thank and highlight a special guest from the University of Arizona, my alma mater, Dr. I have the pronunciation here, so let me give it a shot, and you correct me. Parthasarathy. Yeah. Okay, good. Well, I want to thank you for being here, and who leads the Center for Sleep Research and has treated veterans in my district at the VA. The university is leading the world in this research, which impacts all other healthcare outcomes. I'm proud to support these partnerships that foster discovery, innovation, and results. I have three separate questions that I would like to get to. So if you wouldn't mind, I'll pose the question, and if the three gentlemen can address it, and I can go to the next one as well, so we can cover all three areas. Mr. Bloom, I'll start with you, if possible. My district has a very high proportion of seniors with diabetes. In all of Arizona, out of the 1,727 eligible patients, only 63 veterans are being assisted by your company currently. Could you speak to the taxpayer savings that the remote temperature monitoring program in your company create? And if this is saving money, what is keeping VHA from ensuring every vulnerable veteran has access?
Thank you, Representative Siscomani, for that question. That's a big one. I'll try to go efficient so you can get through them all. The savings per the VA presented to Senate last year is it's about $15,500, $16,000 savings per patient or per veteran participant per year. That typically comes from avoidance in hospitalizations and outpatient visits.
15.5%, is that?
$15,500 to $16,000 per patient per year from avoided hospitalizations and outpatient visits. So the savings is actually quite considerable, yet many of our veterans aren't getting access to it. And there are a number of challenges. So some of the big ones are still just lack of access. We look at our rural veterans or veterans with limited financial resources. They're not able to get to the centers to get enrollment. Unfortunately, the vast majority of riders are VHA podiatrists, but over half of veterans don't have access to VHA podiatry. So right there, you're already losing a ton of access to the tech. And then we talked about budgeted silos being a factor. And of course, I think the incentive structure needs to be addressed. Here's something that has proven savings, dramatic outcomes improvements, including mortality, and yet the workload credit for delivering an amputation is dramatically higher than the workload to prevent it. So that has to be fixed. If we can do that, we can do a lot better.
Thank you. Thank you for that. And I know it was very condensed. I'll have a follow-up if I have time here at the end. But for now, Mr. DiLullo, right? No?
Congressman, you can say anything.
No.
DiLullo. It's DiLullo.
DiLullo. Okay, great. DiLullo. I have also a high number of veterans in my district with lung disease and respiratory disorders, which remains one of the leading health risk factors for veterans, just overall. However, the VA has historically struggled with managing these caseloads, leading to long wait times, which could be very tragic. How can innovative technology help better serve our veterans and ease administrative burdens on physicians specifically?
I'm going to give as quick a thing as I can. This needs a dissertation. So the PACT Act is an incredible piece of legislation. It also has unintended consequences of potentially increasing that problem of backlog of scans and diagnostic imaging or assessments of potential veterans that are at risk due to things that are not detectable in normal cancer or lung cancer CT scans, like constrictive bronchiolitis, DRD, and other symptoms that are common. 75% veterans with those exposures have a much higher lung cancer rate. So what we're doing is working with a partner called Podimetrics that is FDA approved, that we can come in on a simple CT scan for hundreds of dollars at a rate of 20 times faster than you can do a lung biopsy, which is putting a needle in somebody's lung, taking it out, taking the biopsy into a pathology workflow that is thousands of dollars, and I can do it 20 times faster at a 20th of the cost. So hundreds versus thousands, and I can speed diagnostics so I get the right veteran with the right care before it's too late. And we know we have worse outcomes with lung cancer.
Thank you for that. Dr. Parthasarathy, I'm out of time on this one. If there's a second round, I'll stick around to ask you a question, but thank you. I yield back, Mr. Chairman.
Dr. Conway.
Thank you, Chairman Bost. And as has been mentioned, we're here to discuss technology procurement in the VA. And of course, I should say that I'm hopeful always for technology and technological advancement. We do know that we are in the healthcare system, hospital system in particular, we are dealing with shortages of nursing supply. And of course, we want to make sure that we're able, in spite of some of the deficiencies we're seeing there in personnel, that we can fill some of that gap with technology that will allow us to identify someone, as has been mentioned here, who might be failing, who needs a higher level of care. We can get them transferred to an ICU or to a step-down unit so they can be more carefully monitored by more expeditiously finding out if they are deteriorating in their healthcare status. It's very important that we do that. I think I'm not asking this as a question, that many of these things are in the early stages, and because I've heard words like, I hope it may, save and reduce cost, and I say I hope and may, I say that I hope may will become does and will in the very near term, because it will be better for our patients and for the outcomes that we all seek. And we want great outcomes, obviously, for our veterans in the VA system. I must mention a concern at this point in my comments about the many things that we have heard in this committee room and outside of this committee room about deferred maintenance and other very important diagnostic capabilities and equipment within the VA itself. And so while this hearing focusing on technology is very important, it's certainly not without costs, and there are other, and I think you would even agree, more critical devices, equipment in our VA system that is not there now and should be to achieve the outcomes that we want for our veterans. And I'm certainly concerned that we don't have the VA here and now to address some of the concerns we've heard throughout the hearing, since I've been sitting here anyway, about the procurement process. And I will take the chairman's admonition that perhaps we don't know what the cuts in the VA are. I hope that if he's suggesting that there'll be less than the 80 to 83,000 we've been hearing repeatedly in the news is not correct and not knowable now. Okay, I hope that we will see that number, whatever it turns out to be, is far less than the current number. I believe very strongly that hospitals and healthcare delivery, there's a system involved. And that system starts at the physical plant and goes right through security and the people who deliver food and clean the facility and make sure the equipment in there is maintained, right on up the clinicians that are involved in providing the care, and indeed the people that manage the referral process and hears concerns and complaints, so that the hospital itself as a system of providing care can work as well as it should. Mr. Gray, you mentioned in your testimony about the procurement process, and I hope that we'll spend more time. I think this Congress, anything that happens in these departments, from contracting or to procurement, I think we have a right to know about it, because our responsibility is to get that information, deliver it, and present it to the American people, so they can assist us in bringing accountability for the services that receive through their government with their taxpayer dollars. I might add, I shouldn't hesitate to add. You mentioned that the procurement process at DOD
and the VA in some respects are similar and work pretty well, but then you cited the prosthetics procurement process. And can you put some more clothes on that for me? What's going wrong there? Because perhaps if you identify that to us, we can get together and figure out how to get either the resources or help the VA, either by bringing attention to it, that process is improved, because obviously there are a lot of veterans who come back who need a prosthesis to engage in as normal a life as they can in spite of the injuries they've suffered on behalf of our country.
Yes, sir. The great news is we've been working with the ranking member as well as the chairman on this, because we learned a lot of great lessons from the MedSurg Prime Vendor. We think about MedSurg Prime Vendor, that is more for non-implants, so like not pacemakers or defibrillators or knee joints. It's more, this contract is for permanent implants, so typically higher technology, higher cost technology, and so that's the one that needs help. And in terms of what help, clinician involvement in the process, more staff to ensure that they can order the product.
So there's a staffing issue.
Staffing issue there.
And you mentioned inefficiencies. Is that also just staffing or other
Yes, sir.
things?
Yes, sir. Inefficiencies. There's no time to add new products like there is in the MedSurg Prime Vendor contract. In that contract, you have 2 windows a year. There is 0 in the prosthetics contract. So that's one that we need to open up and add technology to. So things like Farapulse, when you're trying to bring that in, it's like, well, there's nothing open. There's no window. You can't add it. And so we're asking questions and not getting answers. So I think that's the one that really needs to get, solved.
Thank you, and thank you, Mr. Chairman.
Representative Kennedy.
Thank you, Chairman. Thank you, Ranking Member Takano, for this important meeting. I would just want to join the chorus of my colleagues in my disappointment that the VA is not here being represented today. There are 4 of you, there are 5 seats, there is an empty chair right there waiting for the VA. They are not here to answer these questions. And when we're talking about the gaps in the industry work that is being addressed by your technology, and first of all, thank you all for your work. Thank you for your commitment to the American people and our servicemen and women. But when we're talking about the highlights in the gaps in industry, we don't have the VA here. That is a major problem. We can't get to the bottom of the issues without the VA being represented here. And when the secretary comes out and says we're going to go back to 2019 levels of staff, that incurs a cut of 83,000 plus people to 399,000 workers, pre-PACT Act, pre-pandemic. We know that healthcare has changed in so many different ways. And so when we're thinking about how the VA will maintain or operate your technologies with drastically fewer engineers and technicians and support staff with 80,000 fewer employees, I find it absurd that they're not here to answer that question. The VA recently canceled 900 contracts affecting things like cancer care, supply chain management, prosthetics, critical areas that directly impact veterans. How can we expect the VA to absorb the cost of new technologies when they're actively cutting these services? Again, I don't expect any of you to answer these questions based upon the fact that these are questions for the VA to deal with directly. You can try, and I appreciate the efforts, but again, there is a very specific service that the VA provides to our military heroes that they've earned and deserve. You are there to complement that work. Without the staff to provide the resources, we are going backwards. Also, as far as maintaining the technologies, to have the cuts that are coming forth to our veterans' services and not having those individuals in place to take care of the technologies. Again, I appreciate the effort, but when we're already talking about a shortage of tens of thousands of workers, where in the community that I represent, in Buffalo, in Western New York, the Buffalo VA had nurses out on the informational picket line because they were understaffed. And we have veterans that are going to the local VA because they love getting the services there. Because they know that those workers that are there, underpaid and overworked, are doing their absolute best and pouring their heart and soul into their work because they care about our veterans. So again, I'm appreciative of your efforts. I appreciate your testimony, each and every one of you. Again, I'm disheartened and disappointed that the VA is not here, and we'll leave it at that. I yield back. Thank you.
Representative Takano, you're recognized for your closing statements.
Yes, Mr. Chairman, thank you. Before I begin my closing statement, I do want to clear up something. Here is a transcript of remarks that Dr. Murphy made earlier in the committee meeting, in which I, in response to my claim, and I quote myself, "This is a prosthetics customer service center that has closed its door in Grenville, North Carolina. That is a VA facility that has been closed in a member's district that sits on this committee." Dr. Murphy, when it was questioning time came to him, responded, quote, "I'd like to correct the ranking member's statement about my VA. The prosthetics department at the VA in Grenville remains open during normal business hours, Monday through Friday, 8 a.m. to 4:30 p.m. to support the needs of vets in the entire Durham VA healthcare catchment." And he submitted, to support his contention that I had given out inaccurate information, he submitted for the record a VISN response. I want to point out that that very response that Dr. Murphy submitted for the record, I'll quote from the middle paragraph, "The prosthetics customer service window at the Grenville VA Healthcare Center, HCC, will remain closed until further notice." That document that Dr. Murphy submitted is dated March 18th. I will point out that this photograph that I had on my poster, which actually shows the Grenville facility being closed, and it reads, "The Grenville VA HCC prosthetics customer service window is closed at this time." That is time-stamped March 21st of this year. I would like to resubmit Dr. Murphy's letter with unanimous consent, as well as the transcript of our exchange.
Without objections?
And as well as the photograph.
Without objection.
So, without question, what is accurate information is that the Grenville Prosthetic Center is closed. We can surmise, and I think we can draw conclusions regarding the staffing cuts that have been undertaken at VA, that might have something to do with this closure. I think this committee needs to hold oversight hearings and get transparency from VA about this very thing. Now, I want to point out also in that document that was provided to the committee, or that Dr. Murphy submitted for the record, is also an exchange between John Clark and Dr. Murphy's staff regarding concerns over, and this is I quote from John Clark, "We have heard from a few constituents in the Jacksonville office front desk now is going unmanned at times due to termination of support assistant, and clinicians are having to either pop out of appointments to help people that walk in or shift their schedule to cover the front desk." Now, the chairman has said there's no five alarm concern here. I would suggest differently. I, as many people know, taught English for a number of years, 24 to be exact. And there's a famous quote in Hamlet where Queen Gertrude says, "The lady doth protest too much," implying that someone is overemphasizing or overacting their emotions or making their sincerity seem doubtful. Now, the gentleman from North Carolina, I could say, is maybe doing both. Protesting too much against my supposed inaccurate statements, but I would also say protesting too little about the staffing shortages that are causing him concern, and that there should be more protest about this particular concern by that gentleman. Now, I want to also further say, in part of my closing, that Secretary Collins has not met with a single Democratic member of the committee in the 2 months since he's been sworn in. Committee Democrats have sent 22 letters to the Secretary, and he has only answered 3, just barely satisfactory responses to the 3, however. Very, very superficial and scant responses. The Secretary appeared on Fox and Friends on March 10th, where he confirmed VA plans to cut the workforce by 80,000. That is a 5-alarm fire about to occur. That is something the Secretary confirmed on Fox and Friends. Well, Mr. Chairman, my hope when I invited VA to be our witness at this hearing was that this would result in a conversation about how we can ensure veterans have access to life-saving technology at a fully staffed VA. Unfortunately, the majority chose to help VA continue to avoid any actual oversight of its staffing and procurement issues by not demanding their presence at the witness table. And as we saw with regard to procurement, there was an actual contract cancellation with regard to procurement or supply chain management assistant. It makes no sense to me why we would be having a hearing about VA's acquisition process without having VA here to talk about it. I can only assume that there's some hesitancy on VA's part to be able to answer questions from all the members of this committee. The many questions my colleagues and I have had about this topic today are left unanswered because we have had no one from VA to direct them to. So sadly, this hearing has turned out exactly to be what I expected, a sales pitch with no bearing in reality. Trump, Musk, and Collins are bleeding VA dry and have so far offered very little information to Congress about where, when, and how they are making cuts. Our many letters and requests for information continue to go unanswered. Again, I want veterans to have it all. Access to life-saving technology presented here today is very much part of what I want veterans to have. And a VA that is staffed to provide them the health care when they need it, and is fully staffed to be able to make this technology accessible. This hearing today gets us no closer to those goals. And until VA starts showing up, these conversations are futile and unproductive. And given Dr. Murphy's own concern about staffing in his own district, Mr. Chairman, I ask you when we are going to have an oversight hearing on the 80,000 cuts that they are planning to do just 2 miles from here, and they couldn't make it over to this hearing.
Well, I want to say thank you to the ranking member for bringing up many concerns. We have since received an email. Actually, the clinic for there that has been in discussion is open. The service window was closed. That's it. A service window has a sign in it. The clinic is still open. And so that's important that we know that.
Mr. Chairman, that clinic is an hour and 40 minutes away from what you're talking about.
A service window is. I just got the answer from the VISN through a VA through an email that there's the event the VA did not close the facility. It closed a service window.
That's exactly what I said, and that's exactly what Dr. Murphy said.
He said the clinic is open. He said the clinic is open.
I offered you the actual quote.
So, with that being said, there are a few other things I would like to bring up. One, it was mentioned, once again, as I said, we're seeing fear-mongering from other side of the aisle. VA's decision to terminate 580, this was early on, non-mission critical duplicative contracts. Instead, it isn't a step backward, but it's long overdue. These weren't core services being cut. Many of these contracts were for duplicative work, like paying a contractor just to produce material for other contractors to execute. That's not modernization, that's bureaucratic bloat. Let's be clear. The nearly $1 billion in recovered funds will now be redirected to what actually matters, veterans' health care benefits, and cutting-edge technology. This hearing was about the future, and I sincerely hope the future in days ahead, my colleagues across the aisle won't immediately turn to the hysteria every time a 24-hour news cycle flashes up. Because trimming the fat is not a crisis, it's common sense. And veterans deserve better than scare tactics. They deserve the results, and that's what I will continue to lead this committee in. One other issue. When we talk about the concern about when is the secretary going to tell us, the secretary is going to tell us like every other secretary. There are a number of items raised, rightfully so, but I will remind the colleagues that there will be plenty of opportunity to engage with the secretary's questions when we hold our hearing on the details of the president's budget, which always comes up. That's when we're going to have the opportunity to do it. And to criticize, let me tell you that majority staff did work, put the request in, VA chose not to show. That being said, let me tell you that as a member, two wrongs do not make a right, but I still think I need to bring this up. When we had a situation with the previous administration where two of the lead people had made decisions to give bonuses to the upper echelon executives, when we asked for them to come, they chose not to send them. Instead, the secretary came. So it is not anything new for whenever we have this happen like this with the VA. I think both sides should work together to make sure the VA is accountable. There's no doubt. But understand, remember, when we're talking about the cuts, they keep saying the cuts, that was a memo, that was not a plan, that was just a proposal to get the people to the table. Now, I've said in this hearing these hearings over and over again, if someone is cut and feel they were unduly cut, then they can contact our offices, they can contact your offices to answer to that question, and we're glad to do that. But also remember, one of the key things that is concerning, that one of the key issues, if someone has been let go, they can appeal to their immediate supervisors. And if your immediate supervisor doesn't think you're essential, I've been in jobs before, and sometimes the immediate supervisors realize, okay, that one's not essential and it's not worth the fight. So I do want to thank our witnesses for coming here today. We're grateful to hear just a few of the many healthcare leaders, and we've learned a lot, I think, through this hearing. We've identified challenges healthcare innovators face in providing cutting-edge quality services and products for veterans through the VA. Together, I believe we can see a day when veterans receive the care they need to regain their strength, mobility, and independence without barriers of access costs. I look forward to working with my colleagues on both sides of the aisle to achieving this goal. Now, again, I want to thank everybody for being here today, and I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extenuous material. Hearing no objection, so ordered. The hearing is now adjourned.